Good morning, everyone. I'm Dr. Chandrakanth, MV. I'm a medical oncologist in Narayana Hospital, Calcutta. Uh, I would thank the organizers for providing the opportunity. So, in coming 10 minutes, I will discuss two publications on triple negative breast cancer. So, we all know that triple negative breast cancer is a disease where we don't have any targets. We are looking for PDL1 androgen receptor. So immunotherapy is coming up. So along with that, we are trying to find new targets. In that, one new target is the the BRD, or the bromodomain target. So bromodomain inhibition is what I will speak in the coming two publications. Uh, the first one is basically a publication on synthetic lethal and resistance interaction with BET bromodomain inhibitors in triple negative breast cancer. So if you look into the electron microscope of the nucleus, you can see what is this beads on string model, which is there on the left upper side. You can see the beads are the DNA and the strings are the histones. So this is what is the chromatin. So the DNA is so fragile that it is wound around histones for its stability to form a nucleosome. So this is what is known as the beads on string model of DNA. And then the lower down, if you look into, so the DNA is wound around the histone, and you can look into what is known as the acetylated ends of the histones. And bromodomains are basically the proteins that regulate transcription. So if I have to go to the exact definition of a bromodomain, it is basically a protein that has 110 amino acids that has affinity for the acetylated lysine residues in the N terminal of histones. So to be very simple, bromodomain is a protein that regulates transcription. Hence, it regulates cell proliferation. If you can inhibit these bromodomains, you are able to reduce cell proliferation. So the we call as BET because the whole nomenclature is bromodomain and extra terminal proteins. You can see in this picture the BET proteins bind to the acetylated residues of the histones. When the binding happens, transcription happens, it recruits RNA polymerase, thereby protein synthesis, and thereby mRNA protein synthesis, and thereby cell proliferation. If you can inhibit this BET, the bromodomain and extra terminal proteins, then the RNA polymerase is not recruited, cell proliferation will not happen. So that is the principle of bromodomain inhibition. So what did the study do? This study looked into triple negative breast cancer patients. It looked into how productive is bromodomain inhibition, and they used multiomics, that is multiple techniques, to assess what are the resistance mechanisms of BRD inhibition, and if you are inhibiting BRD, how productive it is, and can I add other drugs? Are they synergistic? And what are the potential clinical implications? This is what the study looked into. So this is the multiomics model. You can see the epigenomics, proteomics, genomics, and the CRISPR screen. So multiple methods of assessing the BRD inhibition, and the reasons for resistance to BRD inhibition was studied in this paper. So this is what is to be short on CRISPR. It's the clustered regulatory interspace short palindromic repeats. So CRISPR is coming in a big way in that it's basically, if there is a bacteria which is a single cell, when the virus gets infected into the bacteria has special mechanisms of getting the viral DNA into its own DNA and synthesizing CRISPRs, that is the proteins that will fight against further invasion of virus. So we have hijacked this bacterial resistance mechanisms, and now we are looking into editing almost all diseases which are genetic based. And one of the true success stories now is on sickle cell anemia, where with the CRISPR technology we can edit the gene and we can in fact cure these sort of diseases. So that is about the CRISPR screen, which I said. So we're using the CRISPR screen also. They studied the bromodomain inhibition and what are the resistance mechanisms. So if I look into the bromodomain and the extra-terminal inhibition, what are the characteristics? The molecule's name is JQ1, and bromodomain inhibition is very potential. It reduces proliferation, but unfortunately, there is rapid development of resistance in the downstream pathways. So that's the problem. So the responses are not durable. So what are the reasons, or what are the escape mechanisms for developing resistance? So this is the way the BRD4, which is one of the main bromodomain, which is actually active. So if you inhibit the BRD4, that is one of the main bromodomain, then the cell proliferation is inhibited. So so these are the highlights. So to just add, CDK4/6 is an escape mechanism. So if I add a CDK4/6 inhibitor, then I may have a synergistic action with bromodomain inhibition. So what are the mechanisms of resistance? CDK4/6 escape mechanism, EGFR, BCL2, PIK3, AKT, mTOR pathway. These are the escape mechanisms in the downstream pathways. So what are the clinical implications? If I just use a BRD inhibitor or a BET inhibitor like JQ1, yes, I get responses, but the responses are short-lived. So I must combine something else with the BET inhibitor. So it has synergism with fulvestrant, CDK4/6 inhibitors in a triple negative breast cancer, taxanes, Vinca alkaloids, which are chemotherapy drugs, PIK3CA, mTOR inhibitors, and of course, EGFR inhibitors like cetuximab. And the other way is also true. For example, if there is resistance to PIK3CA inhibitor or resistance to chemotherapy, then BRD activation is an escape mechanism. So if I give single drug, there is an escape in the other pathway. So if I can give both BRD inhibition plus chemotherapy together, or BRD plus CDK4/6 together, on those occasions, I can delay the development of resistance and I can have a durable response. So this is the potential clinical implication, and we need to have large studies to understand the clinical implications of this. So to conclude, BRD basically controls chromatin remodeling and it controls oncogene expression. BRD activation is a resistance mechanism in various cancers to hormonal agents, EGFR blockers, and chemotherapy. BRD inhibitor alone, when used, it has short-living responses and rapid development of resistance. And BRD inhibitor has synergy with multiple other anti-cancer drugs. So, so this is about BRD inhibition. What we learned was bromodomain inhibition is important. If BRD is inhibited alone, it's not short-living responses. So I need to have some synergy. Otherwise, the responses are not prolonged or they're not durable. So this is a follow-up paper, just the same lines, another publication where they have used a BET inhibitor with a MEK inhibitor. So as I was saying, just giving a BET inhibitor or a BRD inhibitor is not enough. I need to have a combination. So in this paper, what they have done is they have used a BET and a MEK inhibitor, and they have selected the subgroup of population of triple negative who have the Micn expression by IHC. So this is the same Micn which we saw in neuroblastoma. The similar Micn expression is also seen in triple negative breast cancer in nearly 50% patients. So if you can use this Micn expression by IHC as a biomarker and give BET plus MEK inhibitor combination, then what is the result, and what are the in vitro and in vivo results is what the paper is going to show. So in the background, we know triple negative breast cancer have no target. They are ER, PR, and HER2 negative. And whatever drugs, basically we use chemotherapy or even a chemoimmuno, the responses are short-living. The progression-free survival and overall survival are shorter than the hormone receptor or the HER2 positive counterpart. Therefore, there has always been an effort to identify targets like the androgen receptor, PDL1, HER2 low subtype, and the TROP2 also. So TROP2 is another target where we have sacituzumab govitecan, which has come up in a big way. So we are trying to identify targets, and we are able to find out another biomarker, that is Micn oncogene expression. And the way we find it is the Micn expression is by IHC. So what they have understood is N protein expression is in around 40 to 50% patients in treatment naive TNBC. But if you give a NACT and then if you don't have a PAT-CR in those residual viable cells, the fraction of cells having a Micn expression are higher. So if there is a poor response to chemotherapy or no PAT-CR, they are the cells where the Micn expression is higher and they are susceptible to BET inhibition and BET and MEK inhibition. So what are the types of Micn expression? Micn is basically an oncogene where it causes, it's a transcription factor where it causes fast multiplication. And you can see intrinsic Micn amplification is seen in AML, neuroblastoma and GBM. And we know how fast these diseases multiply and they are lethal. Whereas if you look into the Micn expression in TNBC in prostatic neuroendocrine transformation, so what they say is it is not an intrinsic Micn expression, it is an adaptive way the cell develops its malignant potential over a period of time. So, so it's sort of a adaptive Micn expression and it is heterogeneous. So this is how it is if you have the Micn being expressed and Micn is resulting in proliferation, and we can see the bromodomain which is having an active role, and if I can use a bromodomain inhibitor like JQ1, it is productive and it prevents cell proliferation. So this is again Micn saying that how important it is in physiology, in physiological scenario where it helps in establishment and maintenance of stem cell and progenitor population. And what did this study do? It study basically tried to find out the frequency of Micn expression in TNBC and look into the effect of BET and MEK inhibition and how synergistic it is. So they had 195 treatment naive and 115 patients who received prior neoadjuvant chemotherapy, and they used to find out Micn expression by IHC, and they looked at BET and MEK inhibition with the combination of JQ1 and trametinib. We know trametinib is a MEK inhibitor. And they also studied this in vitro and in vivo, and in vivo they studied with the mice where they were housed with triple negative breast cancer cells. So the results for that, they found out that Micn expression by IHC is present in nearly 45 to 65% cells, and the percentage of Micn is higher if there is residual disease post chemotherapy. So this is a wonderful depiction. You can see in the left corner where you have multiple magenta and green colored signals which are saying that Micn is expressed. Whereas if you look into the right extreme corner, you can see almost a complete disappearance of magenta and green colored circles. So that means that if you are using a JQ1, that is BET and MEK inhibition, it is synergistic in action. Again, the similar thing that has been depicted, if I use a combination, if I use only one BET inhibition or a MEK inhibition, there is always an escape mechanism. Therefore, if I am using a BET inhibitor, I must be using a combination with a MEK or any other combination which I showed in the previous paper. So to conclude, metastatic TNBC has scarcity of targets with whatever treatment we have. We have responses which are short-living. They have a shorter PFS and overall survival. So there is an unmet need in this particular area. So Micn is expressed nearly in 50% of TNBC by IHC, and if there is prior chemotherapy and there is no PAT-CR in those residual cells, the fraction of cells expressing Micn is higher. And targeting Micn, keeping Micn by IHC as a biomarker and targeting this with a combination of BET and MEK inhibitor was synergistic and had durable responses. And these should be tested in larger clinical trials. So I would thank everyone for patient listening. And this is about BET, bromodomain, BET inhibition and MEK inhibition in triple negative breast cancer. Thank you so much.